Sivakumar, cardiologist from Chennai. Today, I am going to briefly discuss about latest update in hypertension. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular disease, which affects 45% people in the 40 to 69 age group. Raised blood pressure is among the most important risk factor for cardiovascular diseases. Moreover, it remained poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people, are 51% of the men and 41% of women with hypertension, were unaware of the condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide, as studied in Lancet 2021. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines, which includes inclusion of optimal and essential treatment paradigms attempt to address the issue that in resource-poor settings. Optimal care refers to evidence-based standard of care, and whereas essential standards refers to minimal standards of care to allow specification of essential standard care for low resource setting. AHA has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease risk. Among low-risk adults, that is no atherosclerotic cardiovascular disease, or 10-year risk less than 10%, with stage 1 hypertension, that is blood pressure 130 to 139 and 80 to 89. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological treatment. And regarding acute respiratory distress syndrome, is a potentially fatal condition involving lung damage, and experts often associated with severe COVID-19. A recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improves respiratory function in people with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to the 110 to less than 130 millimeter range substantially reduces cardiovascular events in the STEP randomized trial, affirming the sprint finding for an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite cardiovascular risk. Finding from nowhere, second major trial supporting a low target could unite the guidelines, which even among US professional societies ranges from threshold of 130 to 150. With regarding to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2000 European guidelines on the management of arterial hypertension recommends that the diagnosis of hypertension should not only be dependent on office blood pressure measuring, but also on the out-of-office measurements such as ambulatory blood pressure monitoring or home blood pressure monitoring. 24 hours and nighttime blood pressure measurement were associated with greater relevant measurement for established cardiovascular risk. For every 20 and 10 millimeter increase of blood pressure measured at night, the risk of mortality increased by 23% and risk of cardiovascular events by 36%. Most patients with hypertension require lifestyle modification to achieve optimal blood pressure control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherent treatment, the importance of combination treatment is particularly highlighted to improve adherence to treatment and blood pressure control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP targets, to start antihypertensive therapy with the initial dual fixed dose combination, which includes ACE or ARB inhibitor with calcium channel blocker or diuretic. Since early July 2018, a product containing valsartan has been recalled worldwide. The reason is of a known carcinogen named N-nitrosodimethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Jian and Hawaii manufacturing sites where the highest level of contaminants were found every day for 6 years in the highest dose, it could result in 22 additional liver cancer over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they have taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visit of more than 6%. The Highgate study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoint that includes death. Highgate chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension, favorable cardiovascular reduction. The largest study included a total of 19,084 patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary cardiovascular outcome. An ambulatory blood pressure was performed for 48 hours to collect data on how BP differs during sleep. The relative risk reduction for cardiovascular events was significantly improved for nighttime treatment when comparing with awakening treatment. Thank you.